We are very delighted today to interview Dr. Lyle A. French, who was president of the American Association of Neurological Surgeons, 1973 to 1974. For those of you who do not understand our relationship, because we're going to be very informal in this interview, Dr. French was a professor and head of the Department of Neurosurgery at the University of Minnesota from 1960 to 1973. He was my predecessor in that position. Dr. French has been a very influential person in the field of neurosurgery, one that you might be calling him a giant. And we are going into the question of his contributions and accomplishments in neurosurgery. But before we get into that, I'd like to ask you a couple of questions, Lyle. Would you tell us your background a little bit about your education, how you get into neurosurgery, and who had some kind of impact on you?
Surely. I went through or took my pre-medical work at the McAllister College in St. Paul, and then came to the University of Minnesota and finished medical school here. During that time, I worked in the experimental surgery lab with Dr. Wangenstein and got to know him and got to be interested in surgery in general. I also, during medical school, had worked with Dr. A.T. Rasmussen in neuroanatomy. And I enjoyed neuroanatomy and because of its preciseness and other reasons. So that when I finished medical school, I took an internship and came on as a resident in general surgery at that time with Dr. Wangenstein. About 1940, the section on neurosurgery was developed because that's the time there became an American Board of Neurological Surgery, and Dr. Payton was the appointed head of that division, actually, of the Department of Surgery. I, at that time, was a resident covering the service, and so I stayed on in neurosurgery because of my interest in developed in part by Dr. Rasmussen, Dr. Wangenstein, and Dr. Payton. I took training prior to World War II and then went into service, at which time I served as a neurosurgeon. And when I finished the service period, I had a fair amount of experience doing technical neurosurgery and diagnostic neurosurgery, so that I wrote a thesis on peripheral nerves and master's thesis on peripheral nerve injuries.
This was sort of the experience you had during the war?
It was during the war, the 100 or so peripheral nerves I had done during the military service. And following that, I decided to get a PhD working with Dr. A.B. Baker, and became interested in brain tumors and cerebral edema. And actually, it was the interest in brain edema that was continued throughout for many years, as you know, as our main interest in our laboratory work. These were the basic reasons I went into neurosurgery. As you know, I took over as head of the department in 1960 for the next dozen years or so, and then I worked as a vice president in charge of health sciences from about 1970 till 1983, and then came back in the department under you. And you served as my boss then for the next few years until I needed to retire.
Dr. Rasmussen that you referred to, yes. He was a neuroanatomist.
He was a neuroanatomist.
He was the father of Dr. Ted Rasmussen.
That's correct. That's correct. A very wonderful guy. Yes. He was a tremendous teacher.
Okay. Now, my understanding was that during the war, when you were in Europe, you also became good friends with John Gallium. Yes,
I got to know John Gallium when I went to England because I was assigned to the head unit at Oxford, and John was working at Oxford, and I remained there for quite some time until we went into North Africa during the invasion of North Africa. And then after the North African campaign, I was assigned to the British in Italy and worked with John to a great extent there too.
Yes, you're still good friends.
We're still good friends in spite of all that.
Yes. Now let's go into neurosurgery a little bit more. What would you consider to be your major contributions in the field of neurosurgery?
Well, I suppose the main thing was the teaching of medical students and residents. After all, the greatest impact a person can have is on the future, what's done in neurosurgery. And I think the residents we trained, the influence one might have on medical students, certainly has the broadest and the longest term impact. I think any educator lives on almost forever through his students in one way or another, and I think that's the residency training program was extremely interested. We did research in various areas, as you know, with radioactive isotopes, with ultrasound, with use of various anti-hydrating or dehydrating agents such as Decadron, but I think the impact mainly was on students.
Yeah. But I think Dr. French is being very modest, or Lyle's being modest. I think you and Joe Glisich were the first ones to use Decadron in neurosurgery in early 60s.
I think we are the first ones to use it directly for brain edema,
yes.
per se. But nevertheless, I still would contend that the training of medical students and residents is the greatest, most pleasurable thing I did.
Well, let me ask you another aspect of neurosurgery. You used to do a large number of intracranial aneurysms, and I recall the way you did some of the tough interior communicating aneurysms. Sometimes you would deliberately open up the aneurysm, put a suction tip down, suck it up, and put a clip on it. How did you decide to do that, or was that sort of serendipitous?
Well, you just worked into that, or we just worked into it, the residents and I together, because one would get an aneurysm that was so turgid or tense that you simply couldn't put a clip across it adequately. It was couldn't get a clip to fit properly, so that we decided that if the resident could hold a suction tip so that the blood would go up that and the aneurysm would go kind of collapse and go up that, I could put a clip on it satisfactorily using a very small suction tip to clean the area around the aneurysm.
You might call this sort of a gutsy approach.
No, it's just having good residents to help you.
Okay.
Without that, you couldn't do it.
All right. Now, you were, as I said, the president of the AANS 73, 74, which was quite some time ago. And in your administration, you must have had a number of policy issues, a number of deliberations. Could you think back and tell us what some of the major issues were?
Yes, I suppose one of the major issues always is membership. I think that without adequate membership, without excellent membership, the association just wouldn't function well. And we wanted an association that would represent the neurosurgeons of the United States, or of United States and Canada. And we had associate memberships too, so that getting into the organization, all the qualified people was very important. I think another one was that I think what we did was to attempt to improve the credibility of the association and of neurosurgeons in general. We tried to organize so that we'd have an impact on what we foresaw as what might be a strong, or what probably would be an adverse sort of involvement of the government and possibly big business on our ability to practice and do a high quality neurosurgery. And for these reasons, we did certain things. Let me explain this a little further. For example, the year before that had been quite cataclysmic, really, as far as the United States is concerned, because we had complaints of shortage of fuel, remember, wheat, beef, so on. There was a rapid escalation of the cost of living at that time. It was a hue and cry, as a matter of fact. We had campaign contributions by corporate organizations, which were, and some of them were indicted for doing this. We had tax evasion by a vice president, and as a matter of fact, we had the whole Watergate affair, so that the credibility of people was being questioned very strongly at that time. And we recognized that that was true, and we recognized that the confidence in physicians, which had been really an important gratification of the practice of neurosurgery, had been tarnished considerably. Our image had been tarnished, so that there were suits, liability suits were escalating, even though the practice of medicine was of the highest quality it had ever been. And we were being assailed to a great extent by politicians for political reasons, and consequently we tried to develop a certain credibility and accountability. We realized that this general myth of immunity that many people thought, that as long as you had practiced a high quality of medicine, as long as you had organizations to review, peer review organizations, so on, that the government would leave you alone and the practice of medicine would go on as it had been. But we recognized that that was not going to be true, because the bottom line for the government or for big business was going to be cost containment. And we therefore developed or promoted the work of some of the committees, such as Medical Liability Committee. Bill Hunt was the chairman of that committee back then, and he did an excellent job working with the AMA. We developed manpower committees, and Kemp Clark was the head of the manpower committee, in order to develop a proper database in which we could make judgments, and so those judgments would have good credibility. We promoted the Social Economic Committee that was chaired by Russ Patterson, I believe.
That was the beginning of the JSEC?
It was the beginning of the JSEC at that time. It was a joint committee between the AANS and the Congress of Neurological Surgeons. Ed Ames was very important in this organization. And in other words, we tried to get ourselves involved in community affairs. We tried to get all the neurosurgeons involved in the committee structure so that they knew what was going on, and we could have an impact of a certain degree on what our future might be. Now, whether we did it adequately or not, I think can be questioned. I don't know. We tried to hold neurosurgery together, too, because at that time there was the beginning of sort of specialty groups like cerebrovascular group, the trauma group, the spinal cord group, all of which are good, very good, but we wanted them to be a component part of the umbrella of the AANS. And of course, as you know, this has come to be, and it's worked very well. We had other activities at that time. The chiropractic groups wanted to sort of invade the territory that we generally think is more prerogative of medicine or nursing, and we had to do a great deal of testimony in that regard. But mainly it was this social economic problem. We foresaw what really has come to pass, and we tried to blunt it and adjust our practices so that if and when it came, we could survive and still do a good, high-quality practice. That was basically the main problems as we foresaw them at that time.
Okay. Now, since then, of course, you know, the environment has changed significantly. Neurosurgery has changed very much too, and so has AANS. I just wondered if you could say a few words, perhaps commenting on what are the positive changes, and if you will, what might be the negative changes.
Well, I suppose those could be divided into a couple of different categories. One is the good things that have happened as far as clinical neurosurgery is concerned, and of course, I think the primary major improvement has been in our diagnostic testing, the neuroradiological testing, the CT scan, the MRI, and so on. That has, of course, entirely changed the complexion of how one does neurosurgery. I think the greater use of the microscope, is, at least for some things, I think sometimes it's used too often, but has been a major impact and has been a great improvement in neurosurgery. I think other things is has to do with a closer relationship or closer review of our training programs. I think they've undergone much greater scrutiny in the latter part of the 70s and early 80s than they ever did back in the 50s and 60s, which has been good. Some of them have been phased out. There have been some of them been improved by such review. I think this is very, very important. I think the neurosurgeons have become involved in community affairs much more than they did before, to a great extent because of the forcefulness of the AANS. I think there have been bad things that have happened. I think that as far as medicine is concerned, or the health care is concerned, we've developed too many specialists as compared to family physicians or primary care physicians. I don't think one can reduce one type of specialist, such as neurosurgery, alone. I think that it has to be different than that, and that is the whole group of specialists should probably have been diminished a bit as compared to the primary care physicians. That would have been that was not done really too well. It's being done now, and I think this has been a very good thing. I think that adversely, and as far as the practice of neurosurgery is concerned, a lot of the neurosurgeons have sort of run scared as far as HMOs are concerned, fearful that there are too many physicians, too many neurosurgeons, and they joined HMO. And I personally believe the concept of an HMO is not really good for the delivery of health care.
Actually, that was the next series of questions that I would have for you. I was thinking about the change of the practice situation, and you kind of touched upon that already a little bit. Particularly in neurosurgery, we talk about manpower, talk about the malpractice situation, talk about what I would call the compression of service, which means that the physician or neurosurgeon in our situation has very little time to do the amount of service that is necessary for a certain physician, for a certain patient. Because of cost containment, we have same-day admission, same-day surgery, things of that sort. And I just wondered if you have any comments regarding these issues. How can we take advantage of the situation and do the best job as we can?
Well, part of the problem, as you know, is the reports you need to put out. I fortunately lived through a period where it was not nearly as great as you had. We did have a lot of NIH reports, but not reports to attorneys, to insurance companies, to government agencies, and so on, which are very time-consuming. I think one of the things that should be done in that regard is to standardize the reports, so that each unit is not getting a different type of information, and I think that would be very good. I think that if the neurosurgeons would sit back really and take a good hard look at the concept of HMOs, as I mentioned before, and took a good look at the numbers of physicians, the numbers of neurosurgeons that are existent, they'd find that they really are not out of proportion, or if they are somewhat, they're going back into a proper proportion. The number of admissions to medical schools is diminishing. The number of graduates of medical school is diminishing. The same, I think, is true of the number of neurosurgeons, which I think is probably a good thing. We probably did have a little bit of an overshoot, which made people very, very apprehensive. But I don't think they should have been, because there's always a waxing and waning, an ebb and flow of this type of thing, and it works out in the end, and I'd personally be very optimistic about it. The thing I worry about HMO concept, for example, is that when the provider, which would be neurosurgeons in this instance, or any physician, can guarantee his income or improve his income by giving less quality or quantity care, there's a tendency to do that. I think it's a human tendency. I think it's not inherent in physicians. As a matter of fact, I think they probably might do this less than other groups of people, but that to me is a flaw. I think the people of the United States, the population, is going to insist on a very high quality of care, and if that's true, neurosurgeons need to be tuned to that and not worry about their own future in any regard.
Are you saying, Lyle, that the cost issue initially was the important issue, the issue perhaps, but you're saying that now the quality issue is coming up again? Is that what you're trying to say?
Yes, I think that the cost issue is the reason, presumably, for going into these prepaid concepts. It's always been a problem in my mind to know whether that's going to diminish the cost. As a matter of fact, I personally think it will increase the cost, and has increased. I think it's been shown it's been increased the cost. But I do think that this other basic concept of am I going to have greater resources for myself if I diminish the resources for someone else? That is human nature, and I think the concept of the DRGs is bad in a sense, and payment via the DRGs. I get very upset when I hear of physicians, neurosurgeons, because of the method of payment. They'll use a microscope, and a microscope is not really necessary. As a matter of fact, it may not be of any advantage whatsoever, but they use it. And I know of cases that have been used because, and I think, frankly, because it increases the resource to the financial resource to the, or return to the neurosurgeon. I think sometimes stereotactic procedures are done on this same basis. I think we fall into attitudes or doing things which we should really avoid, but it's hard to avoid, human nature being as it is. Going back, Shelley, to things that have been I think harmful to neurosurgery or to medicine in general or to health delivery in general the last 15, 20 years has been the growth of groups of people who are against animal experimentation. Mm-hmm. I wanted to get that in because I think that's important. Without that ability to do certain experiments, I think that we're not going to make the progress we normally have made. I do recognize that some institutions have been somewhat remissful in their attitudes towards maintaining high standards, and I think we should be on and critical of those institutions so that they do tune up their show.
Yeah, I think that's a very, very good point. Could we go back a little bit to education? Your initial comment about your contribution to neurosurgery was that teaching was very important. And talking about graduate education, I always thought that you somehow had a special sense of knowing people, getting the best out of people, and selection of residents.
Did I get the best out of you?
Well, I hope so. I just wondered if you could share with us some of the secrets that you have. How do you select residents, for example?
Well, during the period of 20 years or more that I selected the residents for our programs, I must say a lot of them were somewhat pre-selected for me because they were sent by neurosurgeons that I knew or of whom I had heard to train as neurosurgeons to go back into that practice or go back into a specific university. That helped. Mm-hmm. Obviously, that helps. Any type of pre-selection, I think, is good. I never could make a decision by interviewing a person for an hour or interviewing a person for a couple of hours. I would come out as confused as I went in, and so we developed my wife and I think you were instrumental in this too, the system of having the trainee or the applicant come and stay with us for 2-3 days, stay in our home, and just live with us. And in that way we could sort of tell their intelligence. Of course, we have grade point averages and so on, but we'd sort of get an innate judgment of their innate intelligence, I think. We could determine their maturity. If my wife ever said no about a resident, there's no way we would ever, or an applicant, there's no way we'd ever take that applicant as a trainee. We wanted somebody who was socially adjusted because we knew that if they weren't, they were going to have difficulty with patient relationships. We would try to take one who would, a person who would fit into the service, who might help us if they were somebody that was expert in biochemistry, or that would tend to influence us to perhaps want to take that individual. Someone who might have done some research or be interested in research and had some sort of track record, and I think that would influence. We never would take residents simply to fill the service. We wouldn't take more than we could handle. That is, that we thought we could handle and make good neurosurgeons out of them. That we could teach them adequately or properly train. We would, after they'd come on the service, we would, as you know, we'd vary the training program depending upon the likes or dislikes or the needs, more the needs perhaps than the likes and dislikes of the trainee. We would have some of them in the laboratory more. Some would spend more time in anatomy or basic sciences or on the clinical service. We'd work with them very intimately. We got to know their families, we got to know their children. We worked with them socially as well as in the hospital or during the professional aspect of it, because I think that was very important. We'd try to make them part of the team. We'd try to make them an essential component so they would have pride in what they were doing, have pride in their accomplishments. And when we would, it seemed to me that if they did that, they would develop a certain loyalty. They would try to do their very, very best for you, and of course that would be the best for them too, because they would study hard. They would it's an exacting sort of science, as you know, and when they were trying to emulate me or emulate you, they would take pride in that, and they would work hard, and so they did well. So it's a combination of factors. I think one other thing that you have to have, and you may not like this, but I think you have to have a good faculty working with you. And if you don't have a good faculty or staff working with you, and we had this, as you know, over the years, you can't really train people well. It isn't just one man or one woman. It's a group that does it, and that group needs to get along well. They need to do what I consider a high quality practice. They have to work hard and do a combination of things, not only in the clinical practice but research, and be involved in community or national affairs.
Yep, I think that's again very good points. Now, finally, I'd like to ask you one more question. That is the future of neurosurgery. What do you think is going to happen?
Future of neurosurgery?
I mean, looking at the neurosurgery as a discipline.
I think the future, go ahead.
You know, for example, we've had tools, instrumentation, all these have been developed to a degree. And I think a further development, like a microscope, you know, it's not likely. We've been sort of taking things out of the tissue, of the organ, like a brain. And there's a limitation of technology, all right? Technology in terms of tools we can use. And I just wondered if you could kind of think about it a little bit and say, now, the future of neurosurgery would progress in certain lines, perhaps more basic science oriented, or what do you think?
Well, I guess it's the first time in some 35 years or more that I've really disagreed with you. And that is that I don't think that by any means we've reached the end of technology. I can remember when we developed a cautery that we didn't have to set in the operating room every 15 minutes and thought, oh boy, this is the ultimate, there's no worry anymore. Or we developed suction apparatuses that were in the wall so they had a constant suction instead of breaking down. That was the greatest thing in the world, but technology has improved since then. After all, we've sent people to the moon and that type of thing, which I didn't think could happen quite some time ago. I don't think we have expended our total abilities in developing technological improvements. I do think that the future, if I were a young neurosurgeon and going into neurosurgery, I would get extremely good basic knowledge of immunology, for example. I think that the chemical aspect of this would interest me more, same as back 40 years ago I was interested in the pathology aspect of it. I think that's not done, but it's, if I were a young person, I would go into the immunological aspect of neurological problems. But to say that we're through with the technological, I'm sure laser, for example, has not in any way reached its ultimate ability to help us. I think a trainee should have a very good, well-rounded background in neurological problems, and then they can specialize in some area if they want to prior to finishing their training. And I think that may be a good thing, and especially if it's a combination of clinical and research work. But I do think that the basic science area is where we're going to make the greatest improvement, but not the total improvement.
Yeah. Well, that's very good. Suppose there's a bunch of medical students out there, and they're thinking about going to neurosurgery. What kind of advice would you have for them, in addition to what you just have said?
Well, one of the advices I would get would tell them would be not to be apprehensive about it, because I think the future is good. I'm not necessarily an extreme optimist, but I always have been optimistic about the future. I think things work out, and the people are innately intelligent and innately work hard, and with that we're going to succeed in almost anything we want to do. I think the medical students, if they are thinking of going into neurosurgery, should get some sort of background in a basic area. Whether they do that just prior to going into neurosurgery or after they've gone into neurosurgery, I don't think it makes much difference. But I think that whatever it is shouldn't be done on just a 3 months or a 6 months basis. It should be carried out in continuity or over a longer period of time. I think if you can get that trainee to do some sort of investigative work, doing it with the professor or the assistant professor, some of the staff, have them involved in it, have them help write the paper, and this is a little bit off what you were suggesting. I think that putting that trainee's name first on that paper when they've done a fair amount of work on it, contrary to what I've read in some of the journals, is a very good thing, because they then become more a component of the team. They're going to work harder and probably have a greater continuity in investigative work. Getting back to what I'd tell the medical students, work hard and not worry about the future and not try to get it all done in one day. during their training program, accept the fact they're should get a good basic science knowledge and do some experimental work, because I think that helps them all through their practice from then on in. They should go into a training program that has adequate clinical work. Without that, I think they're at a disadvantage. I think they should go into a program that has a fairly broad staff or faculty, not just 1 or 2 or 3 people, but 6, 7, 8 or more if they can, because I think this adds to it. I think it's best if they can go into some program that has a great deal of ancillary services, such as biochemists, physiologists, anatomists, or even engineers
they may not
can be called
like
on.
to be called ancillary services.
No, they're ancillary to neurosurgery. They're not ancillary to health care or to practice of medicine, if you want to call it that. But I think if it's a fairly well-rounded university, for example, it's much better than having going into a training program that's somewhat isolated.
Mm-hmm. Okay, I'm sure we can go on discussing, ask you many, many more questions, but I think the time probably is a factor. And I want to thank you very much, Lyle, for sharing your thoughts with us.
Enjoyed very much talking to you.